All right, I'll start by sharing my screen here. All right, let me take a look here. Thank you so much for the opportunity to be here with you today and for the very warm welcome, Dr. Mellons. I was saying to Claude and Chris before we began that I had a deep dive into the center and folks affiliated and just took a peek here at the attendee list, and it's such an honor to be here. Quite honestly, the work that I do has really been built on the foundation of the work that many of the folks engaged in your center have done. And I recognize some research heroes and real giants on the call, and I'm just really honored to be here. So as mentioned, I'm Dr. Ashley Lacombe-Duncan. I use she and her pronouns, and today I'm honored to share my talk entitled Transforming HIV, STBBI, Prevention and Care, Affirming Human Rights, Interdisciplinary, Community-Based, and Intersectional Research to Advance Health Equity Among Trans and Gender Diverse Communities. As mentioned, I'm an associate professor of social work at the University of Michigan, and while there since 2018, I've continued to carry out a substantive part of my research agenda in Canada as adjunct scientist at Women's College Hospital, where I co-lead the Trans Women and Gender Diverse People HIV, STBBI, and Health Research Initiative, or TWIRI for short. And I'm going to speak to a lot of that work today, and I'm very interested in having a conversation about how we can bridge our national borders to support each other to continue to conduct meaningfully community-engaged, rigorous, impactful research with trans and gender diverse communities. I am especially honored to be here today on Trans Day of Remembrance, which was started in 1999 by activist Gwendolyn Ann Smith to honor Rita Hester, a trans woman who was murdered the year before. 26 years later, what began as a vigil for Rita has grown into a yearly global day of remembrance, one that honors all victims of anti-trans violence and reminds us how important it is to keep building safer, more inclusive spaces. And I know that I have folks that I'm thinking about today, and many of you on the call may also have folks you are thinking about today, and I want to honor that and make space for that in our connection. I'd also like to acknowledge that the land I am calling in from, Toronto, Ontario, Canada, is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. Toronto is covered by Treaty 13 with the Mississaugas of the Credit. As a settler researcher primarily focused on 2S LGBTQ people's sexual health, I recognize the importance of deconstructing colonial conceptualizations of gender and sexuality and understand sexual and anti-trans stigma as manifestations of colonialism. I'm committed to uplifting resources developed by and for Indigenous people, and today I'm sharing with you this resource developed by the Native Youth Sexual Health Network entitled You Are Made of Medicine, a mental health peer support manual for indigiqueer, two-spirit, LGBTQ, and gender nonconforming Indigenous youth. And there will be a link to a Google document that has all of the resources that I mentioned, as well as my reference list that can be shared at the end of the talk. So I'm going to start by telling you a bit about what brings me to this work, my program of research and approach, and why focus on trans women and gender diverse people's sexual health. I'll then highlight the transformative capacity of interdisciplinary, community-based research, providing examples from a decade of TWIRI's research, solidifying an understanding of barriers and facilitators to HIV, STBBI prevention and care, and gender-affirming healthcare among this population in Canada. I'll discuss how we have addressed these barriers through the generation of new clinical knowledge, the use of implementation science, and knowledge mobilization. And I'll end with a focus on future directions, what we can do from both a clinical and research perspective to advance trans health equity in the context of our work. So my overarching research agenda seeks to advance health system equity and improve healthcare access among 2S LGBTQ women and gender diverse people with HIV, particularly through conducting research that can lead to the transformation of care at the provider, organization, and systems levels. I carry out that work through co-leadership of TWIRI in Canada, the Sexuality, Relationships, and Gender Research Collective in the US, and globally through collaboration with Mobilizing for a Research Revolution to ensure LGBTIQ inclusion, or MFAR Asia. I was driven to address healthcare access barriers from my own experience growing up in a rural community in southwestern Ontario, where I first saw the cracks in Canada's universal healthcare system, watching my family struggle without access to local doctors or the means to travel for care, and developing a deep understanding of how socioeconomic precarity further entrenched health disparities in my local community. A specific interest in understanding stigma and discrimination in care was fostered, and particularly among those living with HIV, was fostered as a Master of Social Work student, where I began volunteering at an HIV hospice and completed an internship providing low barrier harm reduction services to women experiencing intersecting HIV stigma, sexism, racism, anti-trans stigma, sexual stigma, substance use stigma, and sex work stigma. And I was particularly disillusioned by the ways in which health and social service providers, who I thought were being trained to be empathic, compassionate, non-judgmental, and caring, like I was being trained, were perpetuating those stigmas. And it was also during my Master of Social Work degree that I came out as a queer person. And so I was navigating my own healthcare, becoming acutely aware of the gaps in competent care available to myself, even in a large city center such as Toronto. And even as I recognize my own many privileges as a white, cisgender, non-disabled, and university educated person. So I really approached this work rooted in my training as a social worker and scholar who's committed to cultural humility, self-reflexivity, and ongoing critique of power and privilege. And I see myself as a vehicle for social justice. And so you will see some unapologetic kind of vulnerability and humility and transparency when it comes to my talk and my approach to my work. When deciding which population to focus on, beginning my research, community leader and activist Yasmin Prasad shared with me a need for research centering trans women, inviting me to do this work with her. Inspired by intersectionality, Black feminist scholars and activists, including Audre Lorde, Patricia Hill Collins, and Kimberly Crenshaw, my first sole author publication described an intersectional perspective on access to HIV-related healthcare for trans women, a conceptual framing that, in combination with other multi-level and intersectional conceptualizations of stigma, really inform how I understand the everyday experiences of 2S LGBTQ communities and women with HIV in healthcare. Throughout my presentation, you will hear some stigma concepts repeated. So structural stigma refers to laws, policies, and institutional practices that restrict trans and gender diverse people's access to resources and care. So for example, insurance exclusions for gender affirming surgeries. Interpersonal stigma occurs in the context of interpersonal interactions, such as providers misgendering or refusing care to trans patients. Individual stigma involves a person's adoption of society's negative attitudes inwards towards themselves and can lead to shame and avoidance of healthcare due to anticipated discrimination. Importantly, intersectionality can also be used to explore one's ability to shift power relationships within institutional contexts, and therefore my work also explores how trans and gender diverse communities resist intersecting stigmas and exhibit resilience and resistance while navigating and dismantling hostile health systems. So why focus on HIV and STBBIs among trans and gender diverse populations? In 2013, just as I was embarking on my research, a newly published systematic review and meta-analysis showed trans women had 49 times the odds of being affected by HIV compared to all adults of reproductive age. This staggering statistic highlighted an immense global gender inequity in HIV prevalence. The most recent global systematic review and meta-analysis published in 2021 reported the overall odds ratios for HIV infection were 66 for trans women and 6.8 for trans men, which demonstrated that trans men also experience HIV inequities. Studies, particularly from the US, also suggest disparities in rates of other non-HIV STBBIs, including chlamydia and gonorrhea, among trans and gender diverse folks. And quite simply, the high rates of HIV and STBBIs among trans and gender diverse people constitutes a global public health crisis. Measures to identify trans women and gender diverse people are routinely absent from national surveillance systems, including in Canada. So filling this gap earlier on in my research trajectory, our team conducted a retrospective chart review of the electronic medical records of 1,495 trans women across 7 family medicine, endocrinology, and HIV clinics in Montreal and Toronto, which are 2 of Canada's largest cities, called the Montreal-Toronto Trans Study, or MTTS for short. Based on data excluding only those only receiving care at the endocrinology clinic, we identified an HIV prevalence of 7.5% among 1,059 trans women, whereas the overall HIV prevalence in Canada in 2021 was approximately 0.17%. Another Canadian study, which was drawn from a community sample, identified an HIV prevalence rate of 1.6% among trans people, compared to 0.1% among cisgender or cis controls. So we do see these inequalities in Canada as well. This increased HIV and STBBI vulnerability can be contextually understood through a social determinants of health lens that recognizes that contexts of social and structural inequity, namely anti-trans stigma, limit trans and gender diverse people's access to inclusion, income, education, employment, and healthcare, which in turn increases vulnerability and impedes access to prevention and care. So using our MTTS data, we conducted a multivariable multinomial logistic regression analysis comparing documented HIV positive status and missing HIV status, which could be seen as a proxy for not having received an HIV test, relative to documented HIV negative status. We found that being HIV positive was associated with older age, Black race or ethnicity, being a landed immigrant or refugee, receiving social assistance, and having ever used recreational drugs. These findings have substantial implications for understanding intersecting experiences of trans women with HIV in Canada, and echoed those from the US, particularly showing alarming disparities in HIV among Black trans women. These findings also highlight the importance of research and programming at these intersections, including for those who are older or aging, Black, of refugee or immigrant status, experiencing socioeconomic precarity, and who use substances. Over 1/3, or 38.1%, were missing HIV status in their charts. Those missing HIV status in their charts were less likely to be Black or another race ethnicity compared to white, and to report a history of sex work, which means trans people may be screened for HIV consistent with known vulnerabilities across race and the experience of racism, and sex work engagement or the experience of sex work stigma. But the overall high prevalence of missing HIV status data indicated potentially major gaps in HIV testing. Another important finding was that those who had not planned or completed gender-affirming surgery had higher odds of missing HIV testing data, which leads into another critical piece to introduce, and what I'll emphasize throughout today's talk of gender affirmation. So being affirmed in one's gender is a social determinant of health and is multifaceted, including social gender affirmation, such as the use of one's authentic name and pronouns, psychological gender affirmation, including connecting folks to affirming mental health support for navigating, coping with, and resisting internalized stigma, legal gender affirmation, such as access to legal name and gender marker change, and medical gender affirmation, which typically includes gender-affirming hormone therapy and gender-affirming surgeries. Professional organizations recognize access is medically necessary to support the health and well-being of those who require it, as it improves mental health and quality of life. But gender affirmation does not only affect trans and gender diverse people. Cis people also access gender affirmation, such as hormone replacement therapy and surgery, such as reconstructive mammoplasty or testicular implants. Yet cis people are not subject to the same gatekeeping or construction of exceptionalism in such care as trans and gender diverse people. When I explored this topic in a community-based qualitative study with HIV care providers in Michigan, I was really struck by how differently providers position cis and trans women's clinical care needs, identifying specialized care for cis women with HIV as integral to their practice, such as HIV care during pregnancy, while relegating specialized care for trans women, such as the co-administration of gender-affirming hormone therapy and antiretroviral therapy, as simply beyond their scope. In 2023, the TWIRI team conducted a national cross-sectional survey with 213 trans women taking hormone therapy as part of a study piloting the development of a new scale to measure trans women's satisfaction with hormone therapy. In doing so, we collected broader clinical variables on various outcomes and access to care. And concerningly, we also found that 33.8% of the sample did not know their HIV status, which echoed MTTS findings, shows major gaps in testing. And our multivariate analyses found that the only factor statistically significantly associated with knowing one's HIV status was having planned or completed gender-affirming surgery, compared to not. These findings echo those from the US, underscoring the critical importance of gender-affirming healthcare for the optimization of HIV STBBI outcomes for trans and gender diverse people. And pivotal findings published just this year in Lancet HIV from Dr. Sari Reisner's legacy cohort study of over 8,000 trans and gender diverse patients enrolled in primary care. Those receiving gender-affirming hormone therapy had significantly lower rates of HIV seropositivity, and among those living with HIV, lower risk of viral non-suppression. So these results add to those, highlighting the clinical impact of embedding medical gender affirmation within HIV and STBBI care settings, which is a very large focus of my work. And importantly, it's not just medical gender affirmation, but social gender affirmation from one's provider that improves HIV and STBBI prevention and care outcomes. So this slide depicts findings from the quantitative arm of my NIH-funded community-based explanatory sequential mixed method study conducted in partnership with Transcend the Binary. Utilizing secondary quantitative data collected from 528 participants from the Michigan Trans Health Survey and analyzed using multivariable logistic regression, I found that those who reported a very or somewhat inclusive provider had 71% reduced odds of never having had an HIV test. So it's impossible to talk about gender affirmation without talking about the socio-political context that promotes or constrains access to affirmation for trans and gender diverse folks. So I want to take a step back and look at the promotion of gender affirmation in Canada and the US. So over the past decade in Canada, we've seen very positive advancements in laws and policies that improve access. These include, for example, expansion of gender-affirming surgery access in Ontario, which is our largest province. It has almost half of the entire population of Canada. So we've seen expansion of gender-affirming surgery access in Ontario in 2016 by allowing referrals from any qualified healthcare provider rather than one clinic. Better access to legal gender affirmation from 2018 onwards, such as permitting an X-gender marker on some forms of legal identity documentation. Perhaps most prolific was the passing of Bill C-16 in 2017, which entrenched gender identity and expression to the Human Rights Act of Canada. In 2019, Canada introduced expanded protections for LGBTQ refugees under a newly established Rainbow Refugee Assistance Partnership. And in 2021, the Canadian government passed a federal ban on conversion therapy through Bill C-4. In 2023, Statistics Canada released the first ever available census data on trans and gender diverse communities, and we know that that information is critical for informing health policy. And as of 2024, 2S LGBTQ rights continue to be one priority of the Canadian federal government, as evidenced by investments in research and programming to support 2S LGBTQ people. However, take a breath and a drink. These positive policy changes have occurred amidst a backdrop of anti-trans backlash, most notably here in the US. As of this month, the American Civil Liberties Union was tracking 616 anti-LGBTQ bills, ever increasing every time I show this slide. I know as HIV researchers and clinicians, many of whom are dedicated to 2S LGBTQ communities, that you are likely well aware of the socio-political landscape and the focus of these bills, but it bears repeating here as a call to research as advocacy and affirming practice on Trans Day of Remembrance, the ways in which these bills cause harm, such as by attempting to ban trans and gender diverse people from accessing legal gender affirmation, including reassignment of gender on previously legally changed passports, restricting access to gender affirming healthcare, particularly for young people and people who are incarcerated, restricting access to bathrooms and banning people from participating in sports aligned with authentic gender, and curriculum censorship, particularly sexual health education inclusive of 2S LGBTQ identities and experiences. This viscerally alarming anti-trans movement includes executive orders attempting to erase trans and gender diverse people's existence by recognizing only two quote-unquote biological sexes, outlawing long-standing socially and scholarly recognized concepts of gender, and limiting access to life-saving gender-affirming healthcare federally. These executive orders utilize terms such as extremism and mutilation to entrench fear and hatred of trans and gender diverse people across US society, and this has an effect elsewhere, including in Canada. Canada is not immune. Some Canadian provinces, namely Alberta, Saskatchewan, and New Brunswick, so 3 of 10 provinces, have introduced laws and policies that restrict the rights of trans and gender diverse people, particularly impacting youth, for example, by limiting their ability to use authentic names and pronouns in schools, restricting participation in gender-inclusive athletic or extracurricular activities, and narrowing access to gender-affirming medical care for young people. At the federal level, while research funding remains intact for now, One Party's election platform explicitly pledged to eliminate what it called quote-unquote woke ideology from the public service and from the allocation of university research funding, raising concerns among scholars about potential constraints on future equity-oriented research, akin to what has happened here in the US. This anti-trans backlash is intimately intertwined within a broader anti-gender movement that threatens the health of all women and gender diverse people by attempting to regulate trans bodies and identities, limit access to abortion and reproductive rights, and outlaw research on gender and sexuality. This anti-gender backlash stands in direct contrast to what a plethora of research shows will directly reduce HIV and STBBI disparities and increase access to prevention and care. So taking all of this into consideration for the remainder of my talk, I will utilize TWIRI as a case study of interdisciplinary community-based research to action. As mentioned, I co-lead TWIRI alongside community leaders, Asya Gundas and Chelsea Davis, and Dr. Mona Lutfi, a clinician scientist and infectious disease specialist, which was officially founded in 2017. TWIRI envisions a world that proactively educates itself on the experiences of trans women and gender diverse people living with and affected by HIV and has the resources to do so. We achieve this mission through creating and promoting accessible, trans-specific knowledge and knowledge-sharing platforms that are respectful and inclusive of all trans and gender diverse identities, in partnership with a very large team of community members, researchers, learners, and clinicians. An important aspect of our work is ensuring that the knowledge we generate is shared, particularly with frontline staff and management working with trans and gender diverse people. So I'll highlight here the 3 TWIRI conferences to date, which brought together over 200 community members, clinicians, and researchers from the Greater Toronto area to discuss the needs and experiences of trans and gender diverse people in HIV and holistic healthcare. These conferences are carefully planned with community at the center, and by centering community voices, they allow for a space where community members and service providers can liaise directly with one another with mutual respect and compassion. So while I wish I could tell you about every one of TWIRI's studies, and I have multiple versions of this talk that includes much more than the time I was allotted for, I'm going to speak in depth to 3 specific studies and really briefly to a 4th. And these studies will be used to highlight the power of interdisciplinary community-based mixed methods and intersectional research to understand population-specific barriers and facilitators to care, improve clinical care through biomedical research, and improve clinical care through implementation science. So to start with, under how community-based mixed methods research can support an in-depth understanding of population-specific barriers and facilitators to care, I'll speak to the Canadian HIV Women's Sexual and Reproductive Health Cohort Study, or CHIVOS, which is the largest community-based cohort study of women with HIV in Canada, led by doctors Mona Lutfi, Angela Kaida, and Alexandra Depocamandi. And for me, that's where my research started, with a convergent parallel mixed method study where I utilized baseline cross-sectional data from CHIVOS, collected from 54 trans women from British Columbia, Ontario, and Quebec, which are 3 Canadian provinces, and then conducted semi-structured individual interviews with a subset of 11 participants. My study was the first in Canada to comprehensively document multi-level barriers and facilitators to HIV care, specifically among trans women using mixed methods, as the few published studies till that point had been qualitative and combined trans women with LGBTQ women more broadly, or with cis men who have sex with men. So first, using the CHIVOS data to look at what HIV care engagement looked like for this population. As folks on this call are likely to know, HIV care is conceptualized as a series of steps from diagnosis through linkage to care, engagement, and retention in care, antiretroviral therapy initiation, antiretroviral therapy adherence, and ultimately virological suppression. So this figure depicts the proportion of trans women with HIV in the CHIVOS study at each step in the HIV care cascade, along with 95% confidence intervals, drawing on self-report cross-sectional wave 1 survey data. So we can see here that the most significant gaps were with respect to current antiretroviral therapy use and antiretroviral therapy adherence. So among those who had ever accessed HIV care, just over 3/4, or 78.3%, were currently using antiretroviral therapy. And of those currently using antiretroviral therapy, 2/3, or 66.7%, reported greater than or equal to 95% adherence. Next, I share the factors that were statistically significantly associated with 3 steps in the HIV care cascade: ever accessing HIV care, current antiretroviral therapy use, and antiretroviral therapy adherence. Bivariate analyses were conducted to examine associations given the small sample size. So compared to trans women who had ever accessed HIV care, those who had never accessed HIV care had been living with HIV for a shorter duration, were doing better physically, had a lower prevalence of experiencing violence in adulthood, and experienced more barriers to access to care. Compared with trans women who were currently using antiretroviral therapy, trans women who were not using antiretroviral therapy were younger and had been living with HIV for a shorter duration. They also had more social and structural marginalization, including higher HIV-related stigma, barriers to access to care, anti-trans stigma, and a higher prevalence of insecure housing. Among those using antiretroviral therapy, only intrapersonal factors were significantly associated, such that trans women who reported less than 95% adherence had higher mean scores of depressive symptoms and PTSD symptoms relative to those reporting greater than or equal to 95% adherence. And not pictured here for the sake of space, but aligned with a conceptual underpinning of gender affirmation, a higher proportion of those reporting a detectable viral load were uncomfortable or very uncomfortable discussing trans health issues with their family physician. So ultimately, these findings identified social, ecological barriers to HIV care among trans women with HIV in Canada, including individual, interpersonal, structural, and multi-level barriers. And these are barriers that are also prevalent among women more broadly. However, what makes this unique is that due to the intersection of anti-trans, HIV, and other stigmas, these known barriers are exacerbated for trans women. So for example, 90% of the trans women in CHIVOS had an income less than $20,000 per year, which was a statistically significantly higher proportion than among cis women. The socioeconomic precarity findings in particular echo population level data just released by Statistics Canada, who reported that in 2020, among the population aged 18 and older in the provinces and territories, age-adjusted poverty rates were highest among non-binary people at 17.8%, followed by trans women at 11.1%, and trans men at 10.5%, And in contrast, cis men and women were least likely to live in poverty, each at 7%. Qualitative data were analyzed using framework analysis, and mixed methods data analysis consisted of mixing of the two forms of data through side-by-side comparisons and joint displays, and considering how data converged, diverged, and expanded understanding. So this joint display demonstrates findings learned only from the quantitative or qualitative data sources, as well as those where findings converged and expanded. And qualitative findings in particular expanded on and helped to explain quantitative associations between HIV care cascade outcomes and years living with HIV, physical health-related quality of life, violence, trauma, and depression. Specifically, the qualitative findings showed how physical well-being contributed to women's disbelief or denial of their HIV status, which inhibited linkage to care post-diagnosis, and how declining physical health was often a catalyst for initiating and maintaining current antiretroviral therapy use. Qualitative findings also helped me to understand how violence contributed to both trans women acquiring HIV through violent sexual assault, but could also be the context within which women were diagnosed when accessing emergency care post-sexual assault, where they were often subject to increased anti-trans and intersecting violence by healthcare providers. And as a final exemplar, qualitative findings showed how the context of violence and intersectional stigma create opportunities within which trauma and depression proliferate for trans women with HIV. So now I'd like to highlight some findings specifically related to the intersection of HIV and gender-affirming care for trans women from the CHIWO study, and particularly barriers and facilitators to gender-affirming healthcare for trans women with HIV. Cisnormativity is the assumption that everyone is or should be cisgender, and contributes to the exclusion of trans women and gender diverse bodies in clinical research. And one area where research has been sorely lacking is in clinical research about potential drug-drug interactions between estrogen-based gender-affirming hormone therapy and antiretroviral therapy to promote comfort among both trans women and clinicians with respect to co-administration of these medications. So among our CHIWO's participants, 68.8% were currently taking hormones. However, a critical gap was that only about 2/3 of those who were currently taking antiretroviral therapy had informed their HIV physician of their hormone use. And we also found that physicians didn't all discuss potential drug-drug interactions. So I mixed that up there. So most of the participants actually who were taking antiretroviral therapy and hormones had informed their HIV physician about their hormone use, so 96%, but only about 2/3 of their physicians talked about potential drug-drug interactions. And this was a concern to us because the qualitative findings showed that participants did have concerns about potential drug-drug interactions that would necessitate clinical conversation. For the most part, qualitative and quantitative results converged and expanded on each other with respect to barriers and facilitators to accessing gender-affirming medical care. But I want to highlight one benefit of the mixed methods approach for when findings diverge. We didn't identify a statistically significant association between annual personal income or source of income with respect to access to medical gender affirmation, but qualitatively, participants talked about how accessing social assistance afforded them access to hormones and antiretroviral therapy, so basic medical coverage for their prescriptions, but relegated them to a low income such that they couldn't afford other aspects of gender affirmation, such as travel for surgery. So this really underscored the intersection of ableism with HIV and anti-trans stigma in shaping trans women with HIV's access to gender-affirming healthcare. Despite these many challenges, trans women with HIV fought back against systems that sought to oppress them and had very important recommendations for structural change, particularly trans inclusion and provider education. And one of the biggest learnings for me of this early work was how a hyper-focus on individual health behaviors can disparage people for not accessing care. And I came to see avoidance of care as an adaptive response among trans women when the care spaces they were accessing were either not equipped to manage their specific care needs or were actively stigmatizing them. And so this really influenced my trajectory to focus at the provider and organizational level. Tying this together in a practical way before I move on to the next example, I share here the women-centered HIV care model, which was developed through the CHIVO study. This model frames care as a house, which is built on a foundation of trauma and violence-aware care that prioritizes safety, stability, and attention to intersecting oppressions. The first floor emphasizes person-centered care that addresses social determinants of health, such as housing and income, recognizing that access to the basics of life are needed before one can engage in care. The second floor integrates HIV care with sexual and reproductive health care, and here we include gender-affirming healthcare, as well as mental health and substance use support. Peer support, leadership, and shared decision-making that position trans women as active partners in their care are integral scaffolding and held to the highest importance. So in 2023, we interviewed 17 trans women and trans feminine people affected by HIV about the acceptability, applicability, usability, gaps, and potential adaptations of the women-centered HIV care model to meet the needs of the trans and gender diverse community. And participants were largely satisfied with the model, but raised questions about implementation for trans folks due to concerns around healthcare provider knowledge and capacity to address their specific needs, and healthcare provider knowledge around social and structural barriers to care within broader social contexts. Last year, I did a talk where I walked through each part of the model, applying it specifically to the experiences and needs of trans women and gender diverse people. And the recording of that presentation is available on the TWERI website if you would like to learn more. But I wanted to introduce it here as it conceptually and practically informs how clinicians can holistically address the needs of trans women and gender diverse people with HIV. So next, I'd like to emphasize the importance of community-based research to improve clinical care through biomedical research. Clinician scientist and family physician Dr. Ian Armstrong and I examined gender-affirming hormone therapy access among trans women with HIV using our MTTS data. And we found that a statistically significantly smaller proportion of trans women with HIV were prescribed hormones compared to those without HIV, which led us to understand that the gaps we saw in CHIVOs and that have also been found in US-based studies showing that both trans women and healthcare providers have concerns about drug-drug interactions may be translating into differences in clinical care. To alleviate gaps in knowledge and ultimately to improve clinical care, the TWERI team undertook biomedical research focused on drug-drug interactions. At this point, you may be asking yourself, how does a social work trained PhD do pharmacological research? And to me, that's the very definition of interdisciplinary community-based research. I go where the community need is, and I work alongside a brilliant interdisciplinary team. In preparation for our full DDI study, our drug-drug interaction study, we started with a pilot to test our procedures and gain essential baseline knowledge. Eligible participants in this single-center parallel group clinical cross-sectional study included trans women with HIV taking hormones and antiretroviral therapy, and trans women without HIV taking hormones. Women came to Maple Leaf Medical Clinic, a medical clinic in downtown Toronto, where they had their blood drawn 5 times over an 8-hour period to measure their serum estradiol concentrations. I want to highlight the amazing team at Maple Leaf who engaged in meaningful collaboration to create a space where trans women would be comfortable participating in a study that may be seen as invasive and time-consuming, converting a standard meeting room into one with a living room feel, complete with comfortable furniture, puzzles, and a television equipped with streaming services. Participants were invited to bring a companion of their choice, and for those without a companion or desiring so, they had the option of having a community researcher spend the day with them. It also probably didn't hurt that it's right across from a little bit of a shopping mall. And it was trialing these and other strategies of engagement that we were able to successfully complete our recruitment for both this pilot as well as the full study. So in terms of findings from the DDI pilot, the outcomes included medians and interquartile ranges and geometric means with 90% confidence intervals of estradiol concentrations at each time point, as well as the observed Cmax and the area under the curve, or AUC, which were compared between groups using Wilcoxon rank sum tests. We found that in trans women on hormones, estradiol concentrations were similar between those on antiretroviral therapy and those not, suggesting a low probability of clinically relevant drug-drug interactions. Excitedly, I can also share with you the findings from the full DDI study, which we currently have a revise and resubmit for of our submitted manuscript. So this parallel group study included trans women with and without HIV taking greater than or equal to 2 milligrams per day of oral estradiol plus anti-androgen therapy for greater than or equal to 3 months. Trans women with HIV were on suppressive antiretroviral therapy for greater than or equal to 6 months and taking or switched to the same regimen, which is listed on the slide. I won't attempt to pronounce. And estradiol concentrations were collected at month 2, pre-dose, and then 1, 2, 3, 4, 6, 8, and 24 hours post-dose. Medians of estradiol maximum concentration, or Cmax, time to Cmax or Tmax, and area under the curve, or AUC, were compared between groups using Wilcoxon rank sum test, and the proportion of estradiol for our concentration within the target range were compared using Fisher's exact tests. So in this table, we compared key pharmacokinetic measures of estradiol between trans women with HIV on ART and those without HIV, or the controls. There were no statistically significant differences across Cmax, Tmax, or AUC. There was also no statistically significant difference in the proportion of trans women with as compared to without HIV who had estradiol concentrations within the target range at C4. And this figure, just to drive the point home, visually illustrates these findings. Both curves show a rise in estradiol concentrations after dosing, peaking within the first few hours and gradually declining over a 24-hour period. The similarity between curves reinforces that this specific regimen, at least of ART, does not reduce estradiol concentrations or alter overall pharmacokinetics. And then finally, I'd like to speak to our application of interdisciplinary community-based research to improve clinical care through implementation science, and particularly our efforts to shift the context of care at the provider and organizational level, starting with the Transgender Education for Affirmative and Competent HIV Care, or TEACH study. While there are provider trainings focused on reducing anti-trans stigma and those focused on HIV stigma, intersectional trainings remain relatively novel. And the overarching goal of the TEACH study was to increase providers' ability to provide gender-affirming HIV prevention and care to trans women by increasing their gender-affirming HIV knowledge and perceived competency, while also reducing negative attitudes and biases towards trans women. We undertook a process of intervention adaptation, drawing on 4 of Card and colleagues' 7 steps for adapting an intervention to new contexts, and 5 of the 8 steps of the adaptive model, originally applied to adapt evidence-based HIV interventions by Drs. Wingood and DiClemente. First, we selected Trans 101 trainings, which were delivered by community partners and co-researchers in Toronto, Vancouver, and Montreal, and collected program materials. Next, we identified key evidence-informed components of these Trans 101 trainings to keep, including an emphasis on shared language of gender identity and expression, and focus on human rights and social justice, co-facilitation by trans community members consistent with theories of intergroup contact, and integration of active learning strategies such as case studies. As a team, we also reflected on gaps between the original content and what we hope to achieve, and identified missing HIV-related information to add to this intersectional training. We produced a draft of the intervention, and then our community researchers led focus groups with 26 trans women in Toronto and Montreal, who were a mean age of 40 years, 3/4 of whom were trans women of color, and almost 1/5 of whom had avoided healthcare in the past year due to anticipated stigma. I conducted semi-structured individual interviews with 10 service providers in Montreal, Toronto, and Vancouver, who held a range of roles and had been at their current organizations for 2 to 15 years. Consistent with our other studies, trans women participants shared their experiences of anti-trans and HIV stigma and care, and both trans women and service providers shared the ways in which stigma manifests, such as through what is perceived as inappropriate and judgmental questions about sexual practices with a lack of context. Trans women and service providers both shared how a lack of provider knowledge and competency to provide both HIV prevention and care and gender-affirming healthcare was a barrier for trans women when accessing sexual health services. As this community member shared, They should learn more about, how to, if they have a trans client, they shouldn't wait for the trans client to ask them for hormones. They shouldn't wait for the trans client to ask them about PrEP, even though the trans client is not positive and is not taking a hormone right now. Two prominent facilitators were the provision of trans-positive and trauma-informed care, and closely linked to that idea, autonomy and choice for trans women in selecting sexual health services. Several of the participants discussed the importance of measures that could maximize their autonomy and choice, and the significance of having access to a range of HIV prevention methods without having to go through specialty clinics known to broker those resources. And others highlighted practices that could safeguard privacy and bodily autonomy, such as self-testing or self-swabbing. Beyond this information to inform the content of the intervention, participants also suggested training for all levels and types of staff within an organization, the centering of migrant trans women and trans women who are sex workers, and how to increase accessibility, and further underscored workshops should be trans-led with strong facilitation. So we finalized the intervention and trained our facilitators before piloting Teach with 78 health and social service providers in Toronto. This 3-hour workshop was delivered by trans women, included didactic teaching, open dialogue, and case studies, covered the intersection of HIV and trans and gender diverse content mapped onto our intervention objectives of increasing knowledge, reducing attitudes, biases, and increasing perceived competency. We administered a pre-intervention questionnaire, including sociodemographic characteristics, employment, and past training experiences, and 2 measures assessing perceived competency, attitudes, biases, and knowledge. And for the follow-up questionnaire, we asked about acceptability and re-administered the 2 outcome measures. Among the 78 providers we trained, 86% had never received any prior training on trans women and HIV. And over 1/3 had never received any training about trans identities or communities. The intervention was highly acceptable, with 91.9% of participants stating they would attend another training on trans women and HIV, and findings from paired t-test analyses indicated statistically significant increases on each measure between pre and post intervention. However, qualitative findings showed participants still wanted more information on research about drug-drug interactions between antiretroviral therapy and gender-affirming hormone therapy. And overall, there was still a need for more tangible clinical knowledge when participants felt that the grounding the social and structural factors was strong. So lastly, I'd like to touch on what integrated gender affirmation and HIV STBBI prevention and care looks like on a broad level. So in spring of 2024, TWIRI initiated an implementation science research trajectory funded by the Ontario HIV Treatment Network to bridge individual, provider, and organizational level barriers to integrated HIV STBBI prevention and care and gender-affirming healthcare in Ontario. So we started by conducting an environmental scan of operational HIV STBBI clinic websites in Ontario. And we did this because we know many people rely on online information before seeking care. So clinic websites are a key indicator of inclusion and accessibility. So this scan helped to reveal structural and communicative barriers that might prevent trans and gender diverse people from engaging in HIV and STBBI prevention and care, even before walking through a clinic's door. So we looked at 198 websites and extracted variables of interest, including general clinic characteristics, HIV, STBBI prevention and care services, and most importantly, and what I'll share in this talk, trans and gender diverse community specific considerations, specifically the availability of gender affirmation within HIV, STBBI care clinics, as well as markers of trans and gender diverse people's inclusion on clinic websites. So we found that just over half of included HIV STBBI clinic websites had some sort of visual or textual representation of trans and gender diverse community support or inclusion, such as explicit mention of trans and gender diverse people being served, the pride and or trans flag, imagery of trans and gender diverse people, and or blogs or referral pages for community supports. 1/5 of clinic websites endorsed any non-medical gender affirmation services, including support groups, events, a trans-specific counselor, or identification documentation update clinics. And these services were primarily concentrated in Toronto, Ontario's largest city. Only 21 clinics, or just about 10%, explicitly identified providing any type of medical gender affirmation, including gender-affirming hormone therapy, assessment, counseling, and treatment, or gender-affirming surgery referrals, post-surgical care, or provision of or referral to mental health and other services required for surgical care. And these were also primarily concentrated in Toronto. So I mentioned that this is kind of the very large focus of TWERI moving forward, is how to increase capacity for integrated care. And this really shows us that there's a lot of room to grow in this area. And there are likely a lot of providers who would provide this type of care within these clinics, but don't necessarily have the resources or knowledge of where to start to be able to do so. For the last part of the time that I have here, for the lecture component, I'll focus on steps that we can take. These are some of my ideas, and I'd love to hear yours as well, to advance HIV and STBBI health equity among trans and gender diverse communities as clinicians and as researchers. So first, we can work within our individual and organizational capacity to implement holistic care to support trans and gender diverse folks experiencing intersecting oppressions. So I just offer here some additional resources pertaining to the women-centered HIV care model. Second, we can all seek out and share relevant biomedical HIV and STBBI and gender-affirming healthcare research with community members and colleagues to ensure that people have the information that they need to make the best decisions for their health and well-being. And finally, we can educate ourselves as best we can, and I'll come back to that in a moment. One thing we suspect from our environmental scan is that more HIV and STBBI prevention and care clinics are providing gender affirmation and support of trans and gender diverse folks than what we're able to see online. And recognizing the importance of clinic websites for promoting access, one tangible thing that can be done is to update clinic websites to include visual or visible markers of trans and gender diverse community inclusion, to advertise the availability of gender affirmation support, including social affirmation like peer support programming, psychological affirmation such as trans-affirming mental health care, legal affirmation such as if your clinic provides help with identity documentation updating, probably less so in the US right now, and medical gender affirmation such as availability of integrated gender-affirming hormone therapy provision and surgery referrals. If such services are not available, another option is to advertise partnerships with local community-based organizations that support and affirm trans and gender diverse folks. And we know that in order to provide holistic care, building these partnerships is a must. This is complicated, this ask, especially right now. When I've presented these data to our team, including environmental scan data from other provinces, including those where there are very regressive there's regressive movement towards anti-trans policies. There's a concern about drawing attention to trans and gender diverse services due to the implications for funding, like will our funding get cut if our funder knows we're serving this population? And for clients, will folks be safe if the broader community knows trans and gender diverse people are welcome here? And this is in Canada, where we have entrenched gender identity and expression protections in our Human Rights Code. So this is a conversation I'd be happy to dive more into, including your thoughts on how you spread the word in your spaces about affirming care, particularly in the absence of being able to do so safely publicly. In terms of education, we are all coming at this work from differing levels of exposure to gender diversity and trans and gender diverse people's health. Again, related to cisnormativity, we just simply don't get enough training in most of our allied health professional fields. Luckily, there's lots of great resources already available. So as part of our Ontario HIV Treatment Network funded study, we conducted a scoping review of available online trainings in Canada, most of which are available online and would be available to folks in the US as well. And the details of these are on our TWERI website. And we've separated it by trainings that focus specifically on HIV prevention and care, gender affirming care, and 2S LGBTQ inclusion. And the intersection of those. But importantly, in Canada, none of the integrated care trainings clinically address the intersection of HIV prevention care and gender affirming healthcare still. So we're looking to build on our TEACH intervention and partnering with Rainbow Health Ontario to do so. Looking at US-based resources, there are a plethora, including the Endocrine Society clinical guidelines. So this is specifically resources about how to prescribe gender-affirming hormone therapy if you're in a position to do so. The UCSF guidelines for primary and gender-affirming care of trans and non-binary people, Johns Hopkins Center for Trans and Gender Expansive Health Quick Guide to Hormone Therapy for the primary care provider, among other resources, Cal and Lord Community Health Centers, protocols for the provision of hormone therapy, and the Transline Hormone Therapy Prescriber Guidelines and e-consults by Transline. And there are also a number of online trainings available focused on gender affirmation with opportunities for continuing education credits. And I'll highlight just two here. I have no affiliation with any of these recommended resources and welcome your other recommendations in the Q&A as well. But for medical providers, George Washington University offers a Gender Affirming Care 101, providing hormone therapy with CEUs for pharmacists, pharmacy technicians, and physicians. And another example is the Boston School of Social Work Affirm Labs Gender Affirming Psychotherapy Training with CEUs for psychologists, social workers, and counselors. And finally, the LGBTQIA plus Health Education Center, a program of the Fenway Institute, has over 50 CME-approved webinars and over 100 documents, guides, webinars, etc., on pertinent topics, both HIV-related and trans health-related. And I routinely recommend this resource when I speak to folks in Canada as well. And then I'd like to touch on research with our plans for TWIRI, given escalating concerns about anti-trans backlash in Canada and the devastation of the US research infrastructure in trans health. So we recently submitted a Canadian Institutes of Health Research HIV STBBI community-based research team grant to expand the work of TWIRI across Canada's prairies, where we have seen the greatest escalation of anti-trans rhetoric and introduction of laws to prohibit access to gender affirmation to the west of Canada. And so our grant has 4 main objectives. One is to build community-based research capacity in 5 provinces by hiring trans and gender diverse community research leads and trainees hosted and supported by local community-based organizations and regional teams. And we're looking to embed our community research leads within community-based organizations, given the ways in which particularly trans-led community-based organizations have been struggling with a lack of funding and infrastructure that has only been exacerbated over time. Have community research leads and trainees conduct stakeholder interviews with HIV and STBBI clinics, trans and gender diverse community members, and community-based organization staff to identify ongoing gaps in HIV, STBBI prevention and care as integrated with gender-affirming healthcare, which will inform regional policy briefs. To develop and deliver a robust training program for community research leads, trainees, and other team members to advance intersectional, queer, and trans justice-focused CBR and access to integrated care. And then to roll out a robust multi-level knowledge mobilization strategy to promote trans advocacy, support, and care that has impact at regional, national, and international levels. And here in particular, I'm interested in fostering a conversation about, again, how we can work collaboratively across our borders to ensure meaningfully community engaged and ongoing research with trans and gender diverse communities, particularly those who are most affected at the current time. So through this presentation, I have emphasized how interdisciplinary community-based research can lead to equity-centered transformation of healthcare, creating affirming spaces for multiply marginalized people to access care. Last fall, I attended a talk delivered by Rania Al-Mugamar, a Sudanese-Canadian Toronto-based artist and activist, and she shared a quote at the time about hope not being a prerequisite for resistance, and that resonated very deeply with me at a time when I was not feeling particularly hopeful. But I do find hope every day with my communities. I find hope being here with you. I have immense hope that by prioritizing community experiences and leadership in research and care, that we can work together to create a world that is more just and fair for trans and gender diverse people. We all have a role to play to improve access to HIV and STBBI prevention and care for trans and gender diverse folks. And I hope that this talk has inspired you to think about what you can do and what we can do together. So before we close today, I'd like to thank everyone involved for their invaluable contributions to TWIRI. I get the joy of being the person here presenting to you, but this work has been the work of hundreds of people. particularly our community member partners and leaders, our partnering clinics and community-based organizational sites, our community advisory board, and our many funders. Thank you to Chris for ensuring such a smooth preparation and time for me to join you today. And thank you all also for being here and for your attention today. And I'm very much looking forward to our discussion. And please, of course, also feel free to reach out to me at the email on the slide. That can also be shared for folks who are interested as well in the chat. And with that, I'll stop sharing and look forward to our conversation.